tried to do in Wigan, and again, I'm not here to say everything was perfect, everything was wonderful, and we just woke up one day with this great idea. It wasn't like that at all. And basically, we started with a massive budget problem. A massive crisis was the kind of precipitator for some of this stuff. So 160 million we had to find in savings, because we were number 3 on the list of most cut councils in the whole of the UK, based on austerity, and deprivation is a big factor in Wigan. So we were having to take all that money out, and at the same time trying to protect critical services for 323,000 people. We realised we didn't have any money, but we had 323,000 people, and tried to tap into the assets within our neighbourhoods, within our staff. We also, just slightly disagreeing with the salaried stranger point from Cormac, 89% of public servants lived in Wigan Borough, lived in the neighbourhoods that we were trying to work differently with the residents. They were the community. They weren't just separate from the community, they were part of it. So we really tried to tap into them as neighbours, as citizens working differently with their other neighbours in the place. We did an experiment back in 2010-11 called the Life Project with Hilary Cottam. I don't know if people have read Hilary's latest book, Radical Help, but it does link across to some of the work that Cormac's described and some of the work we did in Wigan. And we basically worked with families whose children were on the edge of care over a period of a year. And we learned a lot from that project about relationships and public servants working differently, building different relationships with people that they were trying to support. We found some horrific outcomes from that work. We were spending 80% of our time assessing families and then referring them on to other bits of the system without actually trying to help them. It was costing upwards of £250,000 a year per family, but it wasn't helping anybody. And all the social workers, drug and alcohol workers, housing officers who were involved in doing that repeatedly over the years, with generation after generation of families very often, found that we weren't actually helping them. So we reversed that to try to make the way that we operated in the Life Project, the way that we worked, as Cormac's described, every day, all the time, building on the assets in communities, building on the strengths in the family, the strengths of individuals, and trying to take off the lanyards, get away from the clipboard, and build a different relationship as public servants, as professionals, as neighbours, as communities working together differently. We also did a piece of work in a different part of Wigan called Scholes with Nesta, a creative councils project. And again, some very similar learning from that, this time working with older people on social care and finding out that our institutions weren't working, they weren't helping them. Day centres where people were being shipped around in a minibus and sat with people that they didn't know, didn't particularly have anything in common with. Again, expensive and just awful outcomes. So the learning from those two things, plus the fact that we had no money, made us realise back in 2010 that we had to do something completely different and redefine the role of public services in the place. So not trying to do things to communities, but very much trying to listen, trying to use ethnography and anthropology. And we actually employed an anthropologist to come and help us to redesign the way that we engaged with residents and citizens and built strong bonds of neighbourliness between them and the public. So it wasn't perfect. It wasn't just dreamt up. It was iterative, and it's still going on. It wasn't about any kind of political or managerial imperial leader. It was around a different culture for place, a different role for public services, working differently, building on assets in the place. So I won't run through all the achievements because they do speak for themselves. The one that I think is quite remarkable, given the funding that we had to take out, and again, public health, completely agree with Cormac, isn't just about behaviour change, it's about deep systemic change. And the thing that I was personally really pleased at when I saw it was the healthy life expectancy figures. So in parts of Wigan, we managed to, in the most deprived areas, we managed to increase healthy life expectancy. So that's years of life with good health by 7 years, which was because we invested in neighbourhood projects and local community projects. It wasn't commissioned in the usual top-down way. It was very much asking people what did they want, what did they need in their neighbourhood to make it to make things work better for them. So we made all the savings. We did loads with our workforce and radically transformed the relationship and the way we worked. So again, I won't spend much time on this because I think Cormac's covered it, but we tried to apply some of Cormac's thinking, Hilary's thinking and the Nesta work from a very traditional approach of, transactional approach, doing things to people with individual service specifications and contracts that don't reflect the way that people live their lives, to a completely different way, focusing on outcomes in the place, trying to build strengths-based programs into neighbourhoods that were based on what people said they wanted, and are constantly listening. So systemic listening is quite hard to get a big foundation trust in a place to listen in a different way. In some places, a foundation trust could be a hermetically sealed organism, some operating anywhere. It could be on the moon. But what we tried to do was get a different connection with all of the organisations, NHS, housing, mental health support services, social care, the police, everybody working differently with our residents. So if we can move on to the next one. So one of the key things that we did was to try to build on some of the principles of neighbourliness and neighbourhoods into the way that we delivered services alongside and with residents. So the NHS 10-year plan says that populations of between 30 to 50,000 are sort of bigger than neighbourhood, but they are ideally placed to develop integrated care and support systems. And we did this over a period of around 5 years altogether, and they're still going on now. So all the agencies working in the place, police, housing, drug and alcohol services, everyone agreed that they would change the way that they operated and work around a different geography, so that we were quite simple, really. We could get public servants working in the same room. I know it sounds a really basic thing, but they weren't sharing. They weren't sharing different ways of working with each other. They weren't sharing intelligence about individuals and families and communities. So we were all separately interacting, doing our own little bit, looking after our own key performance indicator, but not working in a whole system way with families. So one of the things we used as well, which sounds quite technical, and I don't know whether you use it in West Yorkshire, is something called risk stratification, which is basically you identify by looking at all the information you've got in your systems, key number of individuals and families, and you intensively provide support by encouraging local community and voluntary sector organisations mainly to work differently with those families and get them to feel like they have got that support infrastructure around them. Because some people, really struggle to be part of a neighbourhood. There may have been neighbour disputes. There may have been, things going on over the years that have meant that people feel quite excluded, even when they're part of a neighbourhood. So doing some of the things Cormac described around the Syrian family, we tried to do that intensively through people's GPs, where we felt there was a trusted relationship usually, or through schools when it was around children and young people, and had remarkable results. So we worked out there were around 4,000 people who were at risk of an unplanned hospital admission for whatever reason. We thought initially that they would fall into the older end of the age group, but they didn't. A lot of them were in their 40s and 50s with underlying mental health issues, but not kind of bad enough to access any kind of service or support. Very often isolated, not connected into community activity, and not deemed bad enough to get mental health support, which is terrible. So they were being told, go away, get worse, come back when you're worse, and then we'll maybe find you an appointment in another 6 months. So, that's just not the way. And of course, they did go away and get worse, because that's just the way that we process people through our broken systems. So we tried to turn that on its head, and with remarkable results. So within a year, there was within the group that we were working intensively with community and voluntary groups, GPs and schools, we found a 30% reduction in unplanned hospital admissions in that group. That wasn't the outcome we were really interested in, though. It was healthy life expectancy and improvement in social connection. So just moving on to the deal, this is what it is in a very simple, simply described way. It was a social contract, a different relationship between citizen and state. One of the things we did was we froze council tax, general fund element of council tax over an 8-year period, so that it equated to around £550 per person, per household, per year. It's quite a lot of money. And we felt, particularly for people on a fixed income, that was a really important part of our side of the deal. So we managed to make the savings by closing down some of the institutional things that we had in place that weren't working, and trying to encourage our staff to think differently and work differently with residents and build a different bond so that they were no longer salaried strangers. We can move on to the next one. We applied the deal across the board to other aspects of what we did as well. So we found that there was a large number of private sector care providers who had 15-minute appointments, who were probably sometimes the only person that somebody would see in a day for 15 minutes. And we found that the profit margins were really tight in those businesses, and individuals, the people working for those companies, didn't feel they were connecting with the people that they were going in to see and trying to support. So we developed an ethical home care framework which built on some of the principles of asset-based working, and all of the contracts that were based on asset-based thinking, and tried to embed that into our provider market, which meant that we were the 5th most improved, it's on the slide later on, care provider in the UK, in Wigan. We can move on. So there were 6 really simple principles of the deal. The first 3 are there. It was about different conversations. So rather than trying to fix people, seeing people as a unit of need that needs to be intervened, to be resolved, we tried to think about the professional as a partner in a different relationship and a different conversation with the resident. Knowledge of the community, we felt that there was a lot of fractured knowledge about local communities. So GPs in the olden days, when I started in working with communities in Liverpool in 1985, the local GP knew the local community. They were, the local school knew the local community and knew the GP. But those bonds of connection within a place, because of the kind of way that we measure and manage ourselves around Ofsted, CQC, KPIs, very often those neighbourhood bonds have gone. So we were trying to build that up again within all the assets that we had in the place. Integrated place-based teams, I've already described those. We'll move on to the next one. Again, building on asset-based, all the assets in a community. One of the assets that we had in a place called Plattbridge in Wigan was the local McDonald's, and people would think, well, from a public health point of view, that's a disaster. That cannot be an asset. But it actually was that the franchisee from the McDonald's was one of our ex-care leavers and wanted to work differently with young people and had a passion for organising youth sport activities in the local area. So we worked differently with him. Some of the young people who were in McDonald's for the free Wi-Fi, we kind of captured their imagination about what they wanted in the place in Plattbridge and worked to create a youth group that they then ran and managed themselves. But at places, every organisation has assets. You just sometimes have to look harder in some places for them. But local residents told us that the McDonald's was an asset for them. The attitude and behaviour of our staff was really key. So we used anthropology to try to get people to develop a blank mind when they were working with people, rather than just assume they have all the answers, to actively listen in a different way. And we did a lot around workforce training and development, and developed something called the Be Wigan experience, which was every single member of staff from the hospital, every GP, everybody who worked in a school, or the police working in the place went on this Be Wigan experience, which was to try to get people to adopt values and behaviours that were around social connection rather than trying to fix people. And finally, it was, I think the most important thing was around giving the integrated place-based teams the permission to innovate, to just think differently about each neighbourhood, all very different neighbourhoods, and each one, you know, trying to build up the capacity within that neighbourhood, but give staff the budgets and the freedom to do things differently. If we move on to the next one. Ethical home care, again, I don't think I've got time to go through this one, but it was home care, I think, is one of the things that the pandemic has thrown into sharp focus. We've got a lot of work to do in trying to reform social care, and particularly, you know, private sector care homes that have been really hit hard by COVID. They weren't seen as a connected part of the system, and that's our fault, I think, and we need to resolve that. They need to be seen as part of the neighbourhood. So we did a lot of work with our private care home market, and it did really reap rich rewards. Yeah, so it's the third most improved in the country over the last 12 months. And we used asset-based commissioning as part of the care home reform programme. So 88% of care homes in Wigan are either good or outstanding, and with really good figures around delayed transfers of care, which is a real problem at the moment. We can move on. So again, a lot of it was around not a top-down commissioning model through the CCG, but it was around thinking and working differently within those 7 neighbourhood teams and working out what people actually wanted, what local GPs found were gaps in local neighbourhoods. We put altogether 13 million into community and voluntary sector initiatives and ideas that came from the community and voluntary sector, not what we thought as public servants people wanted, is what they thought was important. Like the Froome example, we found a massive reduction in demand for services as a result of building up the community infrastructure. So we had 500 projects funded through the 13 million, all very different. But the most important thing, I think, was that we started them with a different philosophy, that it wasn't about monitoring them and kind of strangling all the innovation within them constantly, but it was about a relationship based on trust. So that you've told us this is important, here's the money, just do it and come back to us and tell us how it's gone. Some things will work, some things won't work, but we've got to try it. We've got to change the relationship with the community and voluntary sector to one of mutual respect, from one of micromanagement. So, you know, hospitals overspend all the time. I chair one, and overspends happen all the time, and we just get off the hook. We just get more money given to us. When a community and voluntary sector overspend, then, you know, they never get a penny again in the future. You know, we're talking about multi-million-pound contracts versus a £10,000 grant for a mental health project. So we've got to treat, you know, both of those scenarios with the same kind of level of trust, honesty, and openness. So integrated care systems, I don't need to tell you the case for doing that. You're already doing it. I think the work that you're doing in West Yorkshire and Harrogate, I've said it to Rob on many occasions, is the best in the country at the moment. It really is, and I think people could learn a lot from the way that you're working differently with residents and in neighbourhoods. Move on to I think it's the last one, no, second to last one. So this is the these are the service lines, and I know, you know, Cormac's mentioned before it's not about services, but I think the trick we've got to pull off is combining some of Cormac's thinking with existing services. I think it can be done. I think there is a way of doing it. So previously, this is what we had in Wigan, and we changed it down to one base very much around neighbourhood demand and need, rather than all of these different things for adult social care, separately interacting with people. You know, I remember when my mum was discharged from hospital, on the day she came home, 22 different bits of the NHS and social care came to see her at home on that day, all in the wrong order. None of them connected with her, none of them asked her about family, friends, neighbours. It was all about Mary with the broken hip. It wasn't about Mary as a person. And, you know, we know that we don't respond well to that as consumers, as citizens, as neighbours. We don't want to be interacting with like that, but, you know, the system says that's what we have to do. We'll just move on to the next one. So the design principles are here, very much based on co-location, sharing of resources, embedding the asset-based work into the way that we redesigned everything, multi-skilling of people so that people could do more than one thing, that they could connect differently, that we could use the risk stratification in those neighbourhoods, and that we could build on some of the assets that we had in primary care and around people's personalised plans. Move on to the next one. So the benefits are massive. Benefits to the patient, the person, benefits to primary care, and benefits to secondary care as well. So from my point of view, it's just a win-win all the way around.